different classes of antibiotics, what are targets of antibiotics. On Wednesday, we'll take the time to discuss choices of antibiotics. So why do we choose one over another in terms of care? And then we'll talk on Wednesday next week about mechanisms of resistance. And we'll actually bring back one of the labs that we talked about, the Tulsi lab, where we were measuring antibiotic resistance or sensitivity by Kirby-Bauer assays. We'll use some of that data to fuel that conversation. And then the next three classes after that actually become applied everything we've talked about. In other words, there's not much new in the book to read. It's more we're going to talk about, all right, so what does antibiotic resistance actually look like and how does it develop? So we're going to bring back concepts of DNA mutation, determining amino acid sequence from DNA level in order to determine what the effects of mutations are on resistance. We're going to talk about viruses again, but in the context of using bacteriophages as a way to actually treat infections, so an alternative to using antibiotics. And then the one right before the next exam, this is still a couple of weeks away, what we're going to discuss is the rise of antibiotic resistance and what can we do to actually slow down that progress. And that's a really timely issue. So I kind of consider that as being like the applied section of this particular unit, and that's how we're going to finish up. But today we want to really just begin with some basic terminology and start to get an understanding of these different types of antibiotics. Okay? I think what I wanted to do, if I'm not mistaken, was actually to go on to Socrative. So if you've got a computer or a phone or something like that, log on to Socrative. We're going to spend most of the day using this as kind of our basis for conversation. And the room, again, is E.C. Pratt, Edgewood College, Pratt, P-R-A-T-T. That is my last name.
Wait, sorry, say that one more time.
E.C. Pratt, shown right up here. I'll zoom in on it if you would like me to. And bigger. That's about as much as I can zoom in. All right. And I'll downsize. All right. So, question number one. Which of the following antibiotics directly inhibits translation? A, beta-lactams, B, quinolones, C, bacitracin, D, aminoglycosides. You can try this without your notes. You can do this with your notes if you want to. Okay? Take your pick. All right. Rather than answer this question directly to begin with, let's just start with kind of a quick review. What kind of molecules do we find involved in the process of translation? So which molecules of the central dogma have a role in the process of translating proteins? RNA what? Well, that would be involved in transcription. I was looking more for like mRNA. That would work. What else? Ribosomes. Two more that I can think of off the top of my head. Amino acids, that would be a third one. tRNA and ribosomal RNA. Ribosomal RNA are part of ribosomes. tRNA bring the amino acids to that site where translation is going to occur. Which of these is most often a target for antibiotics? Is it the ribosome, the mRNA, tRNA, rRNA, or amino acids? Which one functions like an enzyme? Ribosome. Ribosome of those is the biggest target. Okay, and one of the things to kind of point out here is that most antibiotics, they function by blocking an enzyme. Many of them function as what we would describe as competitive inhibitors. And so you may recall competitive inhibitors are going to be molecules that bind somewhere on an enzyme. Where do competitive inhibitors bind?
Active site.
Yeah, they bind to the active site. So that means that oftentimes these antibiotics are actually going to look a lot like the substrate for these enzymes. Okay? In the case of the ribosome, a lot of the antibiotics that inhibit the translation are going to be ones that are inhibiting the ability of the ribosomal subunits to move or block maybe one of those three sites, the E, the P, or the A site in the ribosome, so that it can't properly perform the process of translation. So which of these antibiotics up here has the ribosome as a target? Which of these classes? Yeah, aminoglycosides is the correct answer here. The beta-lactams are going to target what? Cell wall synthesis. Particularly, they target a class of proteins known as the penicillin binding proteins. We'll come back to these later, as this is kind of a really big area for mutation and resistance. Quinolones target what? And I think I have it listed as quinolone or fluoroquinolone. Anybody have that on their worksheet?
Yes, the levofloxacin, right?
Yeah, the levofloxacin. What is that target?
The DNA polymerase and gyrase.
Perfect. Polymerase and gyrase. In other words, it's blocking replication. Okay. All right. So as we're going through this, what we're going to be doing is kind of just checking the homework too. If you have questions as we're going through this, let me know. Should we see how we did? Do we wanna do that? Cool. All right. Not too bad. Next. Which is not a part of triple antibiotic ointment? Neomycin, tetracycline, bacitracin, polymyxin B. This one may not have necessarily come up in the table, but I think it came up in the mini lecture. So triple antibiotic ointment, one of the most widely used antibiotics. In fact, it's probably the only one that I can think of inside the US that's actually available over the counter. Most other ones, you have to get a prescription for, right? Three, as the name would suggest, three antibiotics are in this formulation. Two of them affect cell wall or cell membrane. Okay, and then the third one is a repressor of the ribosome. Sometimes we use the other brand name for this is Neosporin. That's a dead giveaway as to which one is in here. So which one starts with neo? Neomycin, all right? So that one's definitely in there. Which other two are present?
Bacitracin.
Bacitracin is. Polymyxin B is. And those are both what we might consider to be narrow spectrum antibiotics. Molly?
So I guess obviously I'm wrong in here, but when I was filling this out, I had that bacitracin is narrow for gram-positive and that polymyxin B is narrow for gram-negative.
You're absolutely correct. That's absolutely right.
Okay.
So those two are what we would consider to be narrow spectrum.
Right. So they
And
work together.
yes,
Right.
exactly. So as a whole, triple antibiotic ointment is meant to be broad spectrum. What do we mean by that term? Broad versus narrow spectrum. Can somebody give a definition or an example or a description? Yeah, that's probably the simplest definition. Broad affects multiple different types of bacteria, narrow, a few, right? And sometimes what we define as broad and narrow, these are kind of qualitative terms. So the way that I usually think about it is broad spectrum are going to affect gram-negatives and gram-positives. Narrow spectrum are going to affect one or the other, but not both of them. Okay? And there are some exceptions to this. For example, isoniazid and ethambutol, which I think I've got a question for up here. What do those two target? What does isoniazid and ethambutol target? Tuberculosis or mycobacterium. It blocks mycolic acid synthesis, which is a product, that waxy-like substance that's on the outer surface of only on the outside surface of mycobacterium. That's an incredibly narrow spectrum antibiotic. Because gram-positives, the majority of gram-positives, and because gram-negatives don't produce mycolic acid, the antibiotic has no effect on them. Okay? Now, polymyxin B wouldn't have any effect on gram-positive organisms. It only works on gram-negatives. Why is that? What does polymyxin B actually target? Yeah, it basically is targeting the stability of the outer membrane. And so because gram-positives don't have that outer membrane, they're not affected by the antibiotic. Okay? So the point that I'm trying to make here is if a bacterium or a species of bacterium does not have the protein that's targeted by the antibiotic or a feature that's targeted by the antibiotic, it's going to be resistant to that antibiotic. Okay? So that target actually has to be there in the cells. So for this answer, the correct one would be tetracycline. Another antibiotic that targets the ribosome, but this is not part of triple antibiotic ointment. One of the key characteristics of tetracycline, also there's a close relative known as doxycycline. Anybody know what it does to teeth? Breaks the enamel down, makes them soft. They'll turn yellow as well. So high concentrations of doxycycline can have some off-putting effects. All right. Well, number 3, polymyxin B, only used topically. In other words, on the outside. Because why? It only targets gram-negative. It targets the outer membrane. It is not selectively toxic, or it has a high therapeutic index. There's a lot of terminology in this one. Okay, before we answer this one as a group, what I want you to do is turn to somebody else and talk this one out. Give them your answer, they give you their answer. If they're different, try to come to a consensus. You should talk to Lindsay. What'd you say, Lindsay? Not selectively toxic? Why'd you say C? That's a really good point. That's a really good point. They're not toxic to us. And we're able to achieve this because there's enough difference in the genetics and the protein structure between eukaryotic and prokaryotic cells that allow for this to take place. So for example, our ribosome looks similar, but there's enough differences between its structure and the structure of bacterial ribosomes that allow for the antibiotics like neomycin, tetracycline that target prokaryotes. They do very little to our ribosomes. You want to try and target things that are unique to bacterial cells. So what else might be, if polymyxin B targets an outer membrane? Penicillin, what does penicillin target? And this would be the beta-lactams. Targets penicillin binding protein specifically. More generally, what does it target? What does it block synthesis of? Cell wall. Do we have cell walls? Nope, and we definitely don't have ones made out of the same material that bacterial cells use. So we say that the toxic dose for ampicillin, for amoxicillin, for some of these other ones that target specifically cell wall synthesis, the toxic dose is really high. It takes a lot of it to cause somebody to become nauseous, ill from taking it. Right? In other words, it's very selectively toxic. It's toxic to bacteria, not toxic to our own cells.
When it becomes like toxic to the human body, like with the example of the cell wall, even though we have one, is it because of something else?
Yeah, it could be an off-target effect, right? So obviously, and you can get this. So you might get toxicity not because the ampicillin is, not because of its intended function, but there might be an off effect from something else. For example, we can think of chemicals that would be broken down in the liver. Some might be broken down into toxic byproducts. Yeah, I mean the goal of the liver is to detoxify, right? But we can find examples of chemicals and drugs that are inactive when they go into our body, and then once they get into the liver, they become an active form. You can find also examples where when they get into the liver, they become something that is going to be toxic to us. All right? We try to avoid those medications as best as possible. What are some examples of drugs, and these don't have to be antibiotics, that we might consider to be low in their selective toxicity? So what are ones that we take that actually do cause us to get ill at the same time? Narcotics would be a good example. Yeah, absolutely. A strong narcotic would be a good example. What else?
Chemotherapy.
Absolutely. Chemotherapy drugs are a big one. Goal with chemotherapy is to kill the cancer cell before you kill the normal cells, right? That's the design. Well, there's very few differences between a cancer cell that is our own genetic makeup and normal cells in the body. And so chemotherapeutics or chemotherapies for cancer drugs, for example, very low the toxicity is very large, meaning very little is going to cause somebody to become ill. Okay? The other term that relates with this then is this term therapeutic index. Therapeutic index is a ratio, and we'll play with this ratio on Monday a little bit. But the therapeutic index, or TI, is equivalent to the toxic dose divided by the therapeutic dose. And so we want drugs that have larger TIs instead of smaller ones. Meaning the difference between how much somebody has to take to get sick versus how much are they taking to treat an infection, that ratio is very large. Okay? So if you're comparing two drugs, you choose the TI with the larger value. Emma, go ahead.
I guess this is a little bit off,
No, that's okay.
but what do you guess not necessarily like antibiotics, but with drugs that can become like toxic over time to your body, like something like ibuprofen or Tylenol, like if you're taking it
Yeah.
every 4 hours, every day for so much time, like is that just based on the breakdown in your liver and it's over time it's left in your body, or?
I don't know ibuprofen as well, but I think that it actually causes some liver damage. So I think
Yeah.
it's harmful to those cells. The amount that we take at any given time isn't bad, but you're right. The accumulation of it over, or the amount that we're taking over longer periods of time can be quite damaging, right? Honestly, it's monitoring. And I think that's really what it comes down to. So for drugs that like if we don't have a choice, if we have to use one that does have a low therapeutic index, I mean the aminoglycosides, even though they are selectively toxic for bacteria, they do still have some off effect on our cells as well because of similarity, some slight similarities in ribosomes. You're not going to put somebody on an aminoglycoside for 6 months to a year. You want to use drugs that over those long periods of time are going to remain non-toxic to that individual. And there's other things that we have to consider with long-term exposure to antibiotics as well, such as potential for antibiotic resistance to arise as well. So these aren't really simple answers. They're kind of complex, right? And you have to decide like what is it that you're trying to achieve, and at the same time, what are the potential downsides of this particular treatment. All right, next one. I think we've done this a little bit already, but which of these is a narrow spectrum drug or antibiotic that inhibits the synthesis of mycolic acid? Isoniazid, rifampin, fluoroquinolone, or streptomycin? Kelly.
What was the answer to the last one?
The answer to the last one, sorry, I should have given that, was C, which was, yes, selectively toxic.
But it said it's not.
Oh, then that wasn't the answer. It was D.
Okay.
It was the high therapeutic index. No, that's not right. No, I'm going back to it because I'm totally wrong now. We use it topically because it is... Is there a right answer to this one? And when I was doing this, I think I put... Yeah, I thought C was the right answer. It's not selectively toxic because it actually can cause harm to us. And so that's why polymyxin B is considered, even though it's only good against gram-negative, it doesn't have an effect on gram-positive, well, it can affect our membranes as well. And so that's why it's considered to be not selectively toxic, per se. This is probably not the best question, admittedly. But usually we find drugs, again, if they are selectively toxic, if they have low toxicity on humans, that's going to correlate with a high therapeutic index. So actually, the way that this is set up, these are inverses of one another. All right. Sorry. Let's do this one again. Which of these is narrow spectrum? Anybody want to just give the answer for this one since we've covered this a little bit already? Yeah, it's isoniazid. So there are two of them that are particularly useful against mycobacterium infections, isoniazid and ethambutol. Typically, if we're treating somebody for tuberculosis, the treatment would include one of these two and also include rifampin, which isn't necessarily specific to the mycobacterium, but does inhibit RNA synthesis by blocking the RNA polymerase. And so the breakdown of the mycolic acid actually allows rifampin to get into the cells to treat the infection. All beta-lactam antibiotics, narrow spectrum, inhibit cell membrane synthesis, have a common ring structure, or are non-competitive inhibitors. So what are examples of beta-lactams? Penicillin, that's the classical one. What else? What was that? Bacitracin isn't exactly. I don't think so, at least.
Ampicillin.
Ampicillin, amoxicillin, anyone that ends in cillin oftentimes are examples. Other ones that are similarly related are known as the carbapenems. So there's kind of a large group of beta-lactams. There are your penicillin and penicillin derivatives. There are the cephalosporins. And then there are the carbapenems, meropenems, and then the monobactams. These all are antibiotics that will target gram-positives and gram-negatives. So since it can target both, what does that tell us about the spectrum? Broad or narrow? Broad. There are a couple of exceptions. For example, penicillin itself is narrow spectrum. Ampicillin, a derivative of penicillin though, is broad spectrum. Okay. They all inhibit cell wall synthesis. They have no effect on the membrane synthesis though. And they're all competitive inhibitors. They all bind to a class of proteins known as the penicillin binding proteins. They compete with the amino acids that help to create the crosslinks in the bacterial cell wall and block these proteins from performing that function. They all have a common ring structure though. We'll look at this some more in the next couple of days, but that common ring structure looks like this. And I think there's a nitrogen in somewhere that I'm missing, but that structure is true for all beta-lactams. This is the part of the beta-lactam that mimics what is found in the amino acids that the penicillin binding proteins are trying to create. We'll focus on this later because this is a really good example of not only how do bacteria gain resistance through this, but also how do they inactivate antibiotics as well. All right. I think we'll stop there because I want to make sure that we have some time to cover some other parts of antibiotics today, talking about what make ideal antibiotics, and then again talking about spectrum. But before we go any further, are there any questions about the homework or any of the antibiotics that you were asked to look up? So what do I want? Oh, go ahead, Molly.
What is the protein target of the sulfa drugs?
Dihydrofolate synthetase. Do you need to know it? No. No. There are certain ones that I'm not necessarily concerned with you guys knowing. So let's kind of go through that real quick and I'll point out which ones do I want you to know and which ones do I not really care. I would like you to know, and I'm not asking you to know the specific antibiotics, I'm asking you to know the class as I've listed on the left-hand side there. Now some of those classes, that does include a specific name, like bacitracin is a class of its own, all right? But if on an exam or something I were to say ampicillin and bring that up in a question, I would tell you it's part of the beta-lactams, okay? So I'm not all that concerned with the specific examples. I'd like you to know not necessarily whether they're broad or narrow, but rather what does that mean? Okay? So if, for example, we say that ethambutol and isoniazid is narrow spectrum, why might that be? Well, we talk about its role in inhibiting mycolic acid synthesis. For protein targets, the ones that I am concerned with you knowing are the beta-lactams, the quinolone. Oh, apparently I have beta-lactams on here twice. Is that right? Do I have beta-lactams on the list twice? Okay, sorry about that. The chloramphenicol, aminoglycosides, and rifampin, rifamycin. So the last three on there as well. Now I do want you to know that probably the most important of this is knowing what process is inhibited by each of these different antibiotics or different types of antibiotics. So for example, chloramphenicol, the aminoglycosides, they block translation. All right, so translation, replication, transcription, cell wall synthesis, membrane stability. In the case of the sulfa drugs, it's folic acid synthesis or nucleotide synthesis. That I do want you to know. Bless you. All right. Let's take 5 minutes. What I'd like you to do with a partner or with a couple of people is put together a list for me of the following. So that first part of the handout that I gave you. What are ideal characteristics of antibiotics? Actually, before you talk with somebody else, take a minute to jot down a couple of ideas for yourself and then work on a list together. So you may talk then at 11:37.
Can I have a paper?
No. Yes.
Yes.
Selectively toxic. All right. What else?
Resistance.
What do you mean by that?
I don't really know.
Do you mean not resistance
Yeah.
of the bacteria?
Yeah.
Okay. Whew. All right. How about we put microbe is sensitive. What else? High therapeutic index? Yeah. So something that it takes a lot of it to be toxic inside of us, but it takes very little of it to actually be effective. Good. What else? I think selectively toxic is the right word for that. Yeah, but that's a good description of what we mean by selectively toxic. Absolutely. I got 10 spots. There's at least 10 potential answers here. We've only got a third of them completed. Taylor.
Different means of like applying, like topical versus like injection.
Yeah, so we could probably say that in a couple of ways. One might be ease of treatment. The other thing that you're kind of getting to there is being able to apply it at the site of where the infection is actually occurring, right? I'll try to summarize that in... This is not the right term, but something along the lines of we want it to be able to target specifically in a certain area. I'm going to also put down ease of use. I mean, obviously, it's much easier to take an oral antibiotic at home than it is to have to go to a hospital and receive an IV of an antibiotic, right? Other features. Why do people choose to take for, I don't know, naproxen over, or Aleve, over ibuprofen or Tylenol? What do the commercials say? Longer lasting. We want something that's long lasting, or that has a long half-life. So something that isn't necessarily easily broken down within the body. That's a really good key characteristic. We want it to be active in the human body, right? So something that might be long-lasting. Another way to put this is we might not want it to be something that's actually going to remain in the body but doesn't exit by urination or some form of excretion very easily. Not urination, urinated, something like that. I have a tough time with words today. Any other characteristics?
What is that word saying?
It's supposed to say urinated,
Gotcha.
but like not excreted easily
Gotcha.
from the body. Other ones we might consider.
I was just gonna say, like, we do want it to be cheap, but is that
God
actually, like,
bless.
easy to manufacture? Or
It could mean both. It could mean both. So, like, yeah, we'd want something that's easy to manufacture, but probably also something that is not going to be cost prohibitive from somebody becoming well, right? So, and this is something that actually is. We could talk about this all day when it comes to HIV medication. There are some medications that cost $45,000 per year for HIV positive patients. Okay, that's cost prohibitive. Luckily, some insurance companies will take care of that, but if you're an individual without insurance or on Medicare or Medicaid, you're not going to have access to that drug. So we want these to be cheap. And the manufacturing cheapness, I think that the cost of manufacturing does then trickle down to the price of the drug at the pharmacy. Okay. Probably also want things that are not going to, and I'm going to go back to something that Aliona said. Not only the microbe being sensitive, but that this doesn't cause resistance. So no, that's what I thought you meant. So something that's not going to lead to antibiotic resistance. Actually, we've kind of failed on this for the most part. Most antibiotics that we know of, there are a resistant form of bacteria for every single one of them. We've even now apparently got super gonorrhea, which came out for the first time last week. Woo! All right. Yeah, and ultimately the goal is to really treat the bacteria itself, right? And so you would hope that that would then reduce the symptoms that are associated with it. Who in here is allergic to amoxicillin or ampicillin or sulfa drugs? Okay. You want something that is not going to cause the patient to become ill. This can be a little bit different than selective toxicity, but something that maybe not allergenic. Oh, crap. Would be another key characteristic. Annie?
What's actually happening with allergies today?
Usually it's the immune response responding to it in some way, shape, or form. So it usually it's going to result in like release of histamines because the antibiotic is identified as a foreign substance by the immune system. There are a couple of examples. So some people are allergic to all penicillins, whereas other people, like my daughter Reed, she's actually only allergic to, I think it's just amoxicillin. She's got serum sickness, which means she produces B cell antibodies that recognize amoxicillin specifically, but she's perfectly fine against the rest of the beta-lactam antibiotics.
Yeah, I had a question, but it might get a little far afield.
That's okay. We've got time.
Okay.
Honestly, we're going to carry this conversation into Monday. So
the nurse midwife that I used to work with told me once that like she often, when people come through and they're pregnant with like an allergy to all the psyllin drugs, said that often it's like an allergic reaction that happened like early on in life and it like kind of gets stuck on the chart and forever is that way. And she said it's helpful to actually like retest because sometimes you're not and it's like a good group of, and I know if that's something that what she means is that like what you were saying it's not all or that it's like you grow out of, so to speak.
Both are possibilities, or it gets misdiagnosed. So prime example would be, I'll give one from my life. When I was in high school, I had mono. they prescribed me ampicillin because they originally, or amoxicillin, because they originally thought that it was strep throat. I broke out in a rash. They thought then that I was allergic to amoxicillin, and it actually just ended up being, I was one of the lucky 10% of people that develop a rash with mono. And so I'm not allergic to it at all.
But is there also
but-
some debate about with amoxicillin and the reaction being rash, because that can be
a sign of an allergic reaction, absolutely.
but
And,
it
and
can also be like
a symptom of an illness at the same time, absolutely. And so sometimes it's a little challenging to tease out these differences. And when it comes to allergic reactions, especially when you're worried about somebody potentially developing a shock type allergic reaction, or one where you have asphyxiation of the airways, I mean, you try to avoid that as much as possible. And I think that's why there is caution. I think in a controlled setting, being retested, yeah, that's a really good idea, because the beta-lactams are the most abundant of all the groups of antibiotics that we have. There are a lot of really useful ones in there. You're absolutely right. Emma.
I was gonna ask, when you're allergic to like a common drug like amoxicillin, which is used like really commonly in kids, if you have to use a different antibiotic, can it end up leading to like antibiotic resistance since it's like if it's not as a commonly used antibiotic? Like, does that make sense? Like if it's,
Yes.
if it's stronger because you can't use the basic one, can you end up with other problems?
Yes, it is possible. It is possible too. The last one I put up here is solubility. We want antibiotics that are relatively soluble so that they're easy to put into an IV. I mean, some of them we have to solubilize in alcohol, which isn't all that great to deliver to someone, aka a child. But we do want it to be able to dissolve and make its way through the bloodstream into tissue so that it can actually treat the infection. I'm going to leave you guys with one note to think about for class on Monday, and that is this idea again of broad and narrow spectrum antibiotics. So again, narrow spectrum against a small group, broad spectrum against a large group. Where this becomes a very pertinent topic is when we talk about C. diff infections. Really, really important when we talk about those secondary infections. So we'll pick up with that conversation on Monday. The homework for the weekend is it's just a short quiz one. You can take it as many times as you want. It's actually a review of topics that we've talked about before, which is zones of inhibition, minimal inhibitory concentrations, how do you measure them, how do you identify them. There's a worksheet that goes with this one, because the quiz in the past, like people will, based on the size of their computer screens, their answers differ. So print out the worksheet and actually measure zones of inhibition on the worksheet. That's the only piece of advice I can get. Otherwise, have a great weekend. I'll see you all on Monday.
Are you going to hand out the lab practicals?
If you want to see the lab practicals, come to my office.
Okay.
Come to my office to come and look at them.